welcome to the medical report. Our topic for this session is an orthopedic surgeon's approach to the disorders of the spine. And our guest speaker today is Dr. Mark Tantorski, who is a spine-trained orthopedic surgeon. So we're very pleased to have someone who specializes in spine surgery as an expert. So thank you for joining us.
Thank you, Dr. McKay. Pleasure to be here.
Now, Mark is a member of the Chester County Orthopedic Group, and we've had several of his associates here before. So this about completes that group of people, and the entire gamut of orthopedics I think will have been covered by the time you finish today. So that'll be great. What we'd like to do is to just give our viewers an overview of the disorders of the spine that would be of particular interest to them. So could you tell us a little bit how, in your mind, you classify disorders of the spine, and how you think as an orthopedic surgeon when a patient comes in?
Okay. So, first of all, pain in the spine, whether it's the neck or the back, is a very common clinical entity, which over 80% of people through the course of their life actually have back pain or neck pain. When we look at it, individuals usually come in. We determine whether or not they have neck pain or back pain, and oftentimes the individual comes in sent in from a primary care physician who has seen them and evaluated them. When we talk about the different disorders of the spine, depending upon the region, whether it's the cervical, thoracic, or lumbar spine, we first get a history and talk about what their presenting symptoms are. So individuals may have, whether it's the neck or the back, they may have pain confined to that area, or they may have pain that radiates into their arms or into their legs, or they may have symptoms such as numbness and tingling. And then based on those findings or the subjective history that we get from the individual, we then start to go through an evaluation.
So what we're saying here is what you say to your doctor is very, very important, because you're telling us what's wrong with you, basically, maybe not diagnostically, but that they're the only clues he's going to get in his physical evaluation.
I would agree that the history is absolutely of critical importance to kind of get a timeline of how long the individuals had their symptoms, as well as if there was something that led to the onset of that pain. So it's extremely important.
So following that, then you go through a complete physical evaluation, physical diagnosis, and this is before you do any tests.
Correct.
Right?
So, and I think, again, along with the history, the physical examination is extremely important because that clues us in as to what might be the factors causing whatever symptoms the individual have. So we go through an extensive physical examination, which includes having the individual walk back and forth in the office, and then it also have them go through different movements, whether it's their neck or their back, and then we check things like reflexes, sensation, and then muscle strength.
So when he's sticking you with a pin, he's not trying to torture you. He's just trying to see whether you have sensation or not. And that's important, because that leads into now what some of the diagnostic studies that he might order. And oftentimes people need to know how the orthopedic surgeon views the use of these diagnostic studies. So could you explain the difference in the different, we call them imaging studies?
Sure.
Yep.
So again, the history and physical really is, as far as I'm concerned, the most important component of the evaluation. Once we have that completed, then we usually get basic x-rays. Although over the course of my training, oftentimes we see individuals that come in and they'll have an MRI right off the bat, which is extremely helpful in most cases. However, plain x-rays do give us a lot of information. Plain radiographs of the neck or the spine show not only bony structures, which most people think, okay, is there a fracture or is something not in the position, but it also allows us to see the spaces between the bones, and that when you're talking about the spine is extremely important. So general x-rays of the neck or the spine are the first line that we take with diagnostic imaging.
So how do x-rays differ, for example, and when would you go from an x-ray to, for example, an MRI or even a CAT scan for that matter? Yeah.
So as we said, x-rays will show the bony structures very well, but it's also two-dimensional. So what we do with an MRI, once we have the physical exam completed and we take those findings and we want to look at other structures, for instance, muscle, ligaments, joints, tendons, and in the case of the spine, intervertebral discs, MRI allows us to see that much better.
Perhaps on that little model you have there, you could show what you mean by an intervertebral disc.
Sure. So this is a side view of the lumbar spine. And the lumbar spine is made up of 7 bones called vertebrae. And then you have your tailbone, which is called the sacrum. And you can see the different bones. And in between the bones, there's what's called an intervertebral disc. On the back side of that, you have a hollow canal, which has a tube with fluid in it. And within that tube are the nerves that come out and actually provide sensation and the ability to move in your legs. So when we look with an x-ray, it gives us good visualization of these bony structures. And also, it can show the space here between there. However, what it doesn't show, which is helpful with the MRI, is over time, these different discs start to collapse. And you can see that better on MRI. An MRI is more three-dimensional, so not only can we look at it from a side view, but we can also look at it from top to bottom views. And that will allow us to see the disc as it starts to collapse, pressing back on some of those nerves.
So would it be reasonable to say that sometimes the two studies are complementary?
They are.
Yeah.
They are.
Yeah.
I will say, oftentimes, when individuals come in with pure back pain, and it's new in nature, that x-rays are usually sufficient, and we oftentimes don't need to get an x-ray unless the problems persist for an extended period of time, in which we'll reevaluate them, and that may trigger us to get the MRI.
Okay. So let's go into some of the disorders that we run into here in our age population, and we of course have athletes here, so we have some sports medicine. We have terrific tennis players and golfers and so forth, and they're a very active community. But a lot of us also have the old degenerative disorders and things that happen, and besides falling over our dogs and breaking our legs, everything else is usually age-related. So tell us a little bit about the disorder often known as a spinal stenosis.
Okay, so I'll take a step back and say, no fear, because once you hit the age of 30, the degenerative process starts. So whether you're 30 or 60 or 80, that process is in continuum. So what happens is, and this is a spectrum of wear and tear that happens in the spine. Again, with the discs that we have in between here, you start to get, it starts out where it is filled with water. So that a healthy disc has lots of water in it. And what happens over the course of the time, it starts to dry up. Again, part of the aging process. And when that does, you start to get small cracks, and these cracks start to move out. And what that leads to is it leads to an overall flattening of the disc, and that essentially is disc degeneration.
So that's what basically the stenosis is. Now the herniated disc is different from the spinal stenosis per se.
Correct.
Correct. Okay.
So with that degenerative disc disease, you start to get flattening, and what will happen is in the back part of the spine, where that canal is with the fluid, you start to get narrowing. In addition to that, on the back side, you also have what are called facet joints. They're joints that allow your spine to move. Those also start to degenerate. just like an arthritic knee or an arthritic shoulder. That also contributes to degenerative or spinal stenosis, which is part of that whole spectrum of narrowing, which is different from an acute herniated disc. So with an acute herniated disc, it's not the overall process of the disc flattening and bulging, but it's those cracks that I talked about a little bit earlier. Some of the material from the inside pushes its way out.
Now, there's also a term that is thrown around a lot, and it's sciatica. Could you explain what sciatica means?
That's true. It's a very general term. What it means is that you have nerves, as they come out of the lumbar spine, they track down your legs into your feet. And again, they provide sensation and the ability to move your legs. When you get irritation to those nerves, which cause symptoms down into your leg, that is what the general term sciatica means.
And it's named after what? Sciatic nerve?
Sciatic nerve.
Okay,
correct.
so the sciatic nerve's getting pressed.
That's it.
All right. So that then you've gone through a distinction of you know, a narrowing and a disc coming out, a nerve getting pressed. Tell us now what happens when somebody has a compression fracture.
Okay. Yeah, and this is actually a big problem and very prevalent in this country. There's about 10 million people in this country that have osteoporosis, which just means thinning of the bones. And it's a consequence of getting older. It is more prevalent in women. About a little over 3/4 of those 10 million people are women. And that can lead to weakness in the bone. When you have weakness in the bone, whether it's usually in the lumbar spine or the level above, which is called the thoracic spine, you get weakening in this large vertebral body. And what happens is with some sort of event, and it doesn't have to be a major traumatic event, you get compression of the vertebral body itself. And that is what a compression fracture is.
And sometimes it's a simple move, isn't it?
That's
does
it,
Yeah.
yes. We see them actually we see them quite frequently, individuals that come into the hospital, as well as into the office that don't report any significant event. They said they were performing their normal routine at home and they had an onset of severe back pain. And this is one instance where the pain is really localized to the back with this. Unless the compression fracture collapses so much that it presses on the nerves, but usually this is the type of pain that's really confined just to the back, and you don't get any of those symptoms that radiate down into the leg like sciatica.
Yeah. And one of the tests that we didn't talk about in the beginning might be important for you to discuss, and that's the use of bone density studies for these people, particularly the women, they're postmenopausal women.
Very, very true.
And male as well.
Yeah, I agree.
Yeah,
I agree.
yeah.
I mean, there's 2 million men, give or take, in this country that have it. So bone density testing is a way that they can evaluate the amount of, or the how thick your bone is. So there's various tests. In the orthopedic world, by the time we see individuals with osteoporosis, it's usually those tests have been ordered, and the primary care physicians, your regular family doctor, are really good about ordering those tests. And what those tests do is allow us to identify individuals at risk for having these types of compression fractures.
And in the report, they're reporting the density, the actual density of the bone as measured by a standard. I think it's somebody age 18 or something like that.
18 or 25,
somewhere
yeah,
like that.
somewhere in that healthy, I think a healthy 20 or 25-year-old woman.
So you're being compared not with your peers, but with your kids, so in other words. But that's important. So I think that gives you some feel as to the overview, I think, of the disorders that most of us deal with. We're going to talk in our next session a little bit about the interventional approach to the treatment of these. And this will be very interesting because I think there are some things that have occurred in orthopedic surgery that maybe perhaps you've never heard of before. So stay with us, and we'll be back in a few minutes. Welcome back to the medical report. We are going to continue with our discussion of an orthopedic surgeon's approach to back disorders. And again, our speaker is Mark Tantorski, who is a trained orthopedic surgeon with a special training in spine surgery. So again, we thank you again for being with us. We just went through some of the disorders that happen to people as they get older, and some of the tests that are available to help diagnose that. We're going to talk a little bit about the therapeutic approach to these disorders now, and the distinction between when do you do a surgical approach versus just a non-surgical or conservative approach. So perhaps you could tell us a little bit about that.
Sure. So treatment for spinal disorders widely varies in terms of the spectrum. It can be from as simple as activity modification to taking some over-the-counter medication to prescribed medication, and then you work your way through the spectrum, which includes physical therapy, perhaps epidural steroid injections, and ultimately to